That's like having a left brain stemming for 4 hours.
Yes. Fine. Yeah, good morning from New York. Can everybody hear us well?
Hi, hello, Ramesh here. We can hear you loud and clear, and we can see the right images as well. So with me is Dr. Akruti Gupta from Cedars, Dr. Ruby Satpathy from Jacksonville, Dr. Mantosh Panja, Dr. Ravinder Singh Rao, Dr. Rohit Modi, and your own Dr. Sahil Kera, and some new panelists as well. Please go ahead and introduce your case.
Yes, so Dr. Kinney here. I have Gilbert Tan, who is a surgical director on my side, and Parasuram, who is one of the structural attending here. And Dr. Sharma will be joining us shortly because we have our peripheral live going on from here. So we are going to show you the slides. So the faculty involved, you've seen that, nothing to disclose. And we have Lucy, who is our echo physician, and cardiac anesthesiologist is Hanikman. So this is a 77-year-old female who actually presented with dyspnea, fatigue, and pre-syncope for the last couple of months. So past medical history, if you see here, hypertension, hyperlipidemia, had severe aortic stenosis and TAV with 29 millimeter Evolut Pro core valve that was done in 2016. And of course, she has a pacemaker in 2017 after that. Yes. Diabetes. So what we do is we follow these patients for 1 month, and after that for 1 year, and after that she was being followed by her cardiologist. And recently, because of the symptoms, she had, they do yearly echoes anyway, but the recent echo did show that there is significant gradient. This was a transthoracic echo. You see a velocity of 4.6 with a valve area of 6.5. And she has been on medications for her other comorbidities. And she had normal coronaries, even when the previous hour we did a cath yesterday, and normal coronaries there. So this is the CT scan, that's 2017, Gilbert?
Yeah, so this is done, you can see it back in 2016. So you can see the analysis showing the annular perimeter 79, LVOT 78, big sinuses. Overall, the valve was appropriately sized for 29 Evolut Pro. You can see that there was non-coronary calcium was very calcified. So it's very important to do get the pre-TAVR CT if you can when you do redo TAVR, because you want to know whether it's a bicuspid or tricuspid. There might be some fusion on the left, right in this case. And so you want to size appropriately because if you oversize, especially balloon expandable platform, you could get an annular rupture. So next slide. So this is the aortogram of the initial implant. You can see it was a little bit deeper side. This is 2016, remember? It was before cusp overlap and all these other new techniques to reduce pacemaker rate. But we'll show you live on fluoro as well, that you can see the C-type is actually the outer curve backwards. So this valve, Lucy will show you as well an echo, and we will show on CT, that was completely misaligned. So it was totally misaligned, and remember, commercial alignment was not even conceived until 2018. Next slide.
Yeah. So this is a follow-up transthoracic echo where you can see that was original, and now this is the follow-up. Follow-up at 30 days, immediately post and at 30 days post follow-up. And this is 1 year later, we are still okay. You see the mean gradient, some increase, but subsequently okay for many years. And now here we are, which is the transthoracic echo done on 625. Look at the gradient, which is 87, mean of 54 now. So this is a redo CT analysis.
So as you know, many bipartisan released an app, and there's a paper teaching people how to do redo TAV or CT analysis on JAK intervention. So you can see we measured the envelope frame is a bit more complex than SAPIEN. You have to measure site on the inflow of the valve, and you can see that it's quite large and quite circular, but then if you go no 1, no 2, no 3, you can see the calcium from the native non-coronary cuts that we talked about earlier. But more importantly, the envelope valve was actually pretty reasonably well expanded. You can see the mean diameter is around 23. If we go to the next slide, so we go all the way to no 6, so that's where the commissures are. And you can see that it progressively getting smaller, mean diameter around 22. And so we are thinking about using a 23 SAPIEN 3 here because the mechanism is mostly degeneration. Next slide. So again, you can see that the commissures are falling. It's aligned on CT. You can see the 3 marks, and you can see the coronary angles are here. So you can see if we were doing it at around node 5, you should have clearance of both left and the right. But if you go to node 6, then it might be a little bit closer to the right coronary. You can see how we're going to count the nodes. Because for outflow, you can see that particular line that we drew. That would be our kind of what we call neo-skirt plane, because we're going to allow a subleaflet overhang. Not because of coronary obstruction to the left main per se, but to the right is more also important. But also you want to get back to the coronaries afterwards. So if you end up being too high, you're going to jail yourself from coronary access after redo TAV. So there's a bit of a nuances here. Next slide.
Parasuram, do you want to add anything here?
Yeah, I mean, I agree with Gilbert. The good thing is this valve is slightly deeper than what we usually do. And that kind of worked in favor of this patient, because if it was actually shallow, zero deployment, that could have actually put us in a much more challenging situation for doing a redo TAV, especially with the commissures malaligned and the coronary display would be in jeopardy.
Engaging coronaries was not easy yesterday when I was doing coronary angiography, so it makes it clear that alignment is so important.
So Gilbert, this is Sahil. Parsuram made a very good point here. What if you had a shallower implant? What if you were 0 to 1 millimeters in the initial implant? Would your approach change?
Yeah, I mean, that's a great question. So you're going to have to end at node, input alpha at node 4, which is the lowest you can do for SAPIEN in envelope. You cannot go lower than that because there's a risk of valve migration embolization. So in that case, you might have to upsize it to a 26 millimeter because we average 4 nodes, including your. So right now we're doing 2, 3, 4, 5. If you're doing node 4, then you need to do 1, 2, 3, 4. And if you do 1, 2, 3, 4, you likely need to do the 26 valve to oversize. Otherwise, there have been case reports of ventricular migration because of lack of anchoring against the envelope.
What about the coronary risk?
That's a great point. So you know, if you this valve or you find higher, we have done this before live case as well to protect the coronaries. Because obviously you cannot use leaflet modification here. The commissures are totally misaligned.
Yeah. Gilbert, let me ask you. Anu, this is Ramesh. Let me ask you, Gilbert, a question that probably nobody wants to ask. Why not explant it? Because if it is so difficult to get coronary access now, so what is the risk now?
I'm coming to that slide, Ramesh. Give me 1 second. So access was no issue, right?
Yeah, access was no issue. Although this patient had multiple procedures in the past, the iliacs looked actually okay, femoral looks okay, no calcium, and the diameter is good enough for the E sheet. Just to note, the patient has a right Intel iliac and external iliac main set. So our main access was right side.
Yeah, just to further to Parasuram's point, we had some cases where that same side of the initial tower had to become very strong, right? Particularly if the lot of devices being placed, so it might not be a trivial, just a straightforward per close access. So just be aware of that for the audience when they're doing these cases. That may have to dilate the trap a bit more aggressively. Sure.
Yeah. So Ramesh, coming to your point, so when we are calculating STS risk mortality, okay, we have put redo surgical area.
Yes,
we are talking surgical area. So we don't know what is the probably. This is 77. We would say not a lot of comorbidities. What could be for explant? You have that publication and other data which is telling us that this explant surgery, the mortality in hospital, 30-day mortality could be minimum. You see that it is between 11 to 23%. So we are talking probably about 15% even for this so-called patient with a few comorbidities.
Yeah, let's just pause for a moment. This TAV explant. So this valve is 8 years old. So 8 years old, we've seen the explant specimens that a lot of the frame is actually incorporated, impregnated against the adjacent structures. So you're going to have to be very meticulously peeled off the valve from the outflows. You want to avoid injuring the aorta, right? Because then you have to replace the aorta. You have to also have a cross-clamp strategy and cannulation strategy with these tall valves. So tall valve can be very challenging. And because this valve is kind of deep, you don't want to injure the mitral valve, right? Then you now have to do a double valve replacement. So it's not as straightforward as even a really too straightforward like a surgical AVR. It's just an estimate.
Yeah. So, and I'm sure the surgeons, I don't know if you have any surgeons there on your panel, they do not like to do this case. So.
Yeah, and so I think there have been multiple publications so that if you can anatomically redo TAVR safely, then that would be the preferred choice because you saw all the very consistently across all the different studies out there. Even TVT registry that Raj and Carl published recently, the mortality risk is extremely low for redo TAVR in appropriately selected patients.
Gilbert, hey, this is Ruby. Can you hear me?
Yes, hi.
Hi, how are you? I have a question for both you and Anu. One is if you want to comment, if you guys did a CT, I'm assuming you looked for fault, and there was no fault, or did you try Coumadin or Eliquis something before repeating an echo in a month? If you want to comment.
Great question. Great question, actually. Great point. So yes, so the definite diagnosis, if there's elevated gradient on echo after TAVR, is to do a CT to look for halt. In this case, actually, you can see, I guess that we were showing too quickly because now we were live, is that there was actually calcification of one of the commissures of the evolute valve extending to the leaflet. There have been some studies now looking at the pathogenesis of TAVR failure. And interestingly, what they've shown is that even non-calcified leaflets, because they're stiff, I guess, because of the pathogenesis, actually can increase gradient. So it's not even a halt per se. It's the stiffening of the leaflets. We've actually seen it on echo and CT quite not infrequently.
My second question is, are you guys still, I know the valve is a little deep, so less chance for coronary obstruction, but we all know when you're going to deploy the second, tends to move a little up or down. Are you still planning to protect coronaries today?
Well, the left end is pretty big. You don't see the distance, the valve aortic sinus distance. We'll show you. The right, as you go up to node 6, is a little closer. So we don't think we will protect here, but absolutely we have protected before. So this one, even if it rises up to node 6, well, we're not so much concerned about left main. The right might be a little bit trickier. It's what happens afterwards we need to get coronary access. That will be challenging. Let's say this patient have progressive CAD, right now it's non-obstructive. That would be challenging to re-engage the coronary selectively. So that's why I think that if you can, deploy the valve below the coronary risk plane, which is the lowest margin of the coronary takeoff, that would be ideal. But if you cannot, then you can go a little higher with the understanding that you may compromise coronary access afterwards in the future.
Hi Gilbert, this is Akriti. I was wondering,
yes, hi.
How are you? So I was wondering in valve cases which are higher risk for stroke and some seniors, do you consider cerebral protection when you do these cases? Yeah,
great question, great point. And yes, same as the TAV In TAV in surgical valves as well, we would like to protect. Unfortunately, this patient is actually vasculopathy. Despite ultrasound guided, we weren't able to get successful radio access, so we were not able to do cerebral embolic protection. But I agree with you that these patients have a high degree of the thrombotic event from the prosthetic valve, because often what you can see here is very challenging to cross, even though only one leaflet is compromised. We like to pre-dilate to make sure we don't have any issue crossing with the second valve, but also we like to post-dilate to maximize the frame extension of the second valve. So there's a lot of things going on, and so certainly we don't want to cause stroke as a result of that here.
Yeah, I mean, I think in the panelists, you always use Sentinel in all of your patients.
Not all, but the ones that we deem high risk. This would be.
These are the kind of patient basilica when you're doing that, or when you're doing TAV in TAV probably. But that said, actually, Gilbert, I wanted to ask you, we are going to really challenge you from WBU with the Vinay Manwar as well.
AL1.
I think the 11 to 23% mortality that you showed is all comers. But these are really elect patients, and their explant, at least we have done 5 explants in the last month. 2 evolutes in low-risk study who failed after 6 and 7 years. 2 sapiens which failed in 2 years. Both the patients, unfortunately, 69, 72 years of age. And then 1 actually trifecta.
Let me dictate first.
So all of them failed, and we explanted all of them with the 0% mortality. Yes, that's only anecdotal series of 5 patients, but I'm actually pushing my surgeon a lot to actually explant, because these are low-risk patients. And we were talking about for Indian population, when you're using 55 or 60-year-old people getting TAVs, and the longest one, somebody asked me just now outside, what's the longest valve that you have seen? And maybe 8 years. So I did a sapien in sapien for 8 years. I don't know, maybe there's more experience that we need, but be cautious because of the problems that we'll have. And one question that I wanted to ask, anybody is using Darcy solutions for these, Gilbert or Ruby?
I do.
Yeah, so this patient was at the TAV in 2016. The low risk was not approved at that time, right? With just intermediate risk, there was approval in 2015. So this patient would not have been a low surgical risk patient at that time. So if the patient is not a low surgical risk at that time, I don't know what surgical risk was deemed. I mean, now with 8 years later, patients certainly not biologically younger. We would not have deemed this patient a low surgical risk now if the patient was not a low surgical risk later, particularly his TAV explant. I mean, Vinay obviously is an outstanding surgeon, so he can do this. But remember, the average number of TAV explant done per year in the United States, even though it's the fastest growing operation, is 1 or less per surgeon per year. So you can imagine that you guys did 5 in a month. I mean, that's a very high volume, right? It's not trivial to take for the surgeons don't see a lot of these pathologies, because you guys are obviously the center of excellence. But having said that, I agree with you. Some of the registry had included endocarditis. We actually did a redo TAVR versus TAVR explant in only patient with structural valve degeneration. And those patients still have a high mortality. Shinichi from University of Michigan is probably one of the most highest volume in the world, especially evolute explant. His numbers are definitely getting better. But still, it's not just mortality, but the morbidities associated, length of stay, etc.
Yeah, thank you, Gilbert. I have an audience question. Go ahead.
Hello. Yeah, I'm Dr. Vivek Gupta in Apollo, and I'm missing with Samir Sharma to join. Just a quick question and comment. Of course, TAV in TAV is getting will get more and more common as we are approaching 10 years of life of these patients. In India, we started in 2017. I was talking to Dr. Gopal. He said the first case was done in 2015. He's still living. That means 9 years already gone. So I just wanted to have a small comment. I mean, I of course partially agree with Dr. Ramesh that he said surgical would be better. But I think once a patient already had a non-surgical, the non-surgical trial attempt will be always better. I just wanted to know, comparing SCV, I mean, self-expanding versus balloon expanding, which will be easier to do a TAV and TAV? I mean, those patients who are doing it, I mean, the challenge will be the same, or it will be some difference. Ravinder can answer this question. When you are doing TAV in TAV, whether self-expanding versus balloon expandable, which will be more challenging, or it will be equal challenge for both of them?
Great question, great point, and they all have their own subtleties, and you'll see today what the subtleties are. So if the first valve is short valve that fails, so it's most likely balloon expandable valve, as long as you're not going to obstruct the coronaries, and we would prefer to put a self-expanding valve because, especially supraannular valve, because of the hemodynamic improvement. Raj's paper that was in JAMA showed that actually if the second valve is a sapien and you put it into a non-sapien valve, which is in the United States with an evolute, the hemodynamics are actually better than sapien and sapien. So we would prefer to switch to the other two. Most tall valves, like you see today, will get the second valve. Ideally, would be the balloon expandable valve. This is the short valve because we like short and tall versus tall and short. The tall and short combination, which is usually evolute and sapien, you have to be mindful not to implant without too deep, then you lose your hemodynamic benefit. but you also don't want to have too high either before you release, and there's a risk of pop-up. So we try to aim at roughly at the inflow of the sapien, maybe just a little bit higher to get the supraannular benefit. But all these valves, in our opinion, we typically pre-dilate, especially for the balloon expandable valve, because they are usually underexpanded. So we want to kind of prepare the landing zone before you put the second valve in. So you see that today as well, because it's not easy to cross some of these valves, and you also don't want to be hung up when you place the second valve.
I remember some of the Dr. Krivio's patients still alive, maybe 12, 13 years. So we have to wait and we have to learn a lot of things.
I think we will all learn a lot because this is still preliminary. I think SCVs are filling, the surgical valves are filling, balloon expandable filling. Gilbert, that's great answers, but I see Anu has crossed the valve already. I want to comment that crossing the self-expanding valves are actually TAVR valves, more difficult than crossing surgical valves. We have 8 minutes left. Anu, so what have you done so far?
Yes, I agree. So going back, that's an excellent point. So if you see here, I think one other thing that we also need to know why this TAVRs are failing. So probably we got to understand from the beginning itself. When we take care of the calcific coronary arteries, we know how well we need to take care of the calcium before we place a stent. So if you go back to the original CT scan, non-coronary cusp is where you add a lot of calcium, and that's exactly what we are seeing. I think if you see here, if you see that part of the leaflet is not moving. We'll quickly show you just 1 second the TE, because TE is up there.
So Lucy, you want to comment on the TE? Can we show the slide echo, please?
Yeah, real quick, this is live echo on the table TE, and you can see the EF today is a little bit lower than our baseline, so mildly reduced function around 50%. Right heart is normal, and there's no PVL that we can see here is for 5-chamber view, and no significant MR, some moderate TR that you can see. But let's focus on the aortic valve. So here you can see without color first that there's this shadow here that is suggestive of the anatomical non-coronary leaflet being stuck in the closed position. And with color, again, no significant PVL, and you can see wide open flow into the left main.
Okay, yeah. So we're going go 180. Dr. Sharma just arrived. Audience is waiting for you.
Can you show live, please?
Live fluoro.
Off. Please off.
Off. Yes. Okay. Go 180.
180.
And what size balloon is this?
20 true balloon.
20 millimeter true balloon. Okay, we're coming off.
I think that's an important point for the audience.
Space it off.
All right. We don't want to oversight the balloon.
I'm here now. We made it. And I've been listening all the discussion. Beautiful. I mean, the whole today, I have so much discussion on the TAV in TAV. Just like saying, it came back with the DES, restenosis in 2003 and 4. This is the reality. And but I think we all will get very much educated after this India Valve. So much emphasis, so much discussion of the individual points, which valve to be used, and how to deploy, and particularly crossing the core evolute valve rather than going to the straight. They go to the apex. They go to the third wire with the pigtail. Maybe that's the best Sahil was telling me, and I know two other best and I like it. They did it. Yeah.
It's not in the apex, right?
Okay, so what did now tell us?
We have to reposition the wire. You can see it's not optimally placed in the apex. I mean, these procedures, everything can. So you want to make sure that you are.
So Gilbert,
at the apex.
Can you tell us about pre-balloon sizing and how often do you pre-balloon? Why not use a 22 true or a 23 true? And what happens in vitro if you do not pre-balloon and just go with your balloon expandable valve? What happens from in vitro?
Look at the difference now. Just want the audience to see how the wire placement is so critical, because you need to use the wire to your advantage here with this TAV in TAV. We've seen the valve gone up, gone down. It's just really hard to predict. So the first operator is very hard to pull, because if you pull into the inner curve of the valve, and so you end up losing your optimal trajectory. If you push the wire, that's how you can actually set up the valve, pull the wire to let the valve drop. To your point, Sahil, if you be too aggressive with your pre-dilatation, you can run